Good afternoon, everyone, and a warm welcome to EMA FVE info session on restrictions for the use of certain antimicrobials in animals. My name is Zoltán Kunsági. I am the head of Veterinary Antimicrobial Monitoring and Resistance Service at the European Medicines Agency, and I have the pleasure of chairing today's event. This is the sixth event organized jointly by the EMA and the Federation of Veterinarians of Europe FVE to raise animal health professional awareness on key topics related to the implementation of the veterinary medicinal products regulation. The third one on the topic of antimicrobials. Veterinarians stand at the forefront in combating emerging diseases and play a crucial role in mitigating the development of antimicrobial resistance. Regulation 2019/6 introduces specific measures against the emergence of AMR and promotes a more prudent and responsible use of antimicrobial medicinal products in animals, including strict rules regarding their veterinary prescription for prophylactic and metaphylactic use. Today's event will focus on the use of restrictions of certain antimicrobials in animals. We are privileged to have two veterinarians with us, Professor Rory Brenach and Dr. Andreas Palzer, both of whom have contributed significantly to the EMA and WHO lists of antimicrobials reserved for human treatment. After the presentations, participants will have the opportunity to engage and ask questions via Slido. You can access the platform either via www.slido.com and typing the events code available at the bottom right of each slide. You can also access the platform by using your smartphone. Just point the camera at the QR code. Okay, just before we start, and I give the room to the president of FVE for the opening remarks, a bit of housekeeping. First, if you experience audio issues, leave the meeting and log in again. Make sure you selected the correct audio outputs. All attendees are muted by default. Please note that this session is being recorded. By participating, you consent to this recording. If you do not agree, we kindly ask you to exit. The materials shared today will be uploaded on the events webpage in the upcoming weeks, together with the session's recording. Okay, without further delay, I would like to invite Dr. Piotr Kwiczynski, President of the Federation of Veterinarians of Europe, for his introductory remarks. Thank you.
Thank you, Zoltán. So, ladies and gentlemen, esteemed colleagues and distinguished guests, it is a great pleasure for me to be here with you today on behalf of the Federation of Veterinarians of Europe, welcoming you all to another joint organized webinar with the European Medicines Agency. Previous joint webinars were in the field of pharmacovigilance, the categorization of antimicrobials, data collection of cells and use of medicine, and the Union product database. FVE likes to thank EMA for the opportunity to work together on what is crucial for our profession, namely supporting the veterinarians in optimizing treatment of animals. The aim of organizing these webinars is to inform and discuss with our colleagues in the field, mostly veterinarians, but not only, the implication of coming into force of all the new veterinary medicine regulations. Today we will discuss about the list of reserved antimicrobials. These are antimicrobials that are not allowed to be used for animals, but are reserved for treating people only. We will hear more about why this list was made and how experts decided which antimicrobials should be reserved only for people. You will also hear about the differences between the EU and WHO approach, each having different lists, and what is the relevance of each of these lists for you. Please realize that this webinar is your webinar. We don't want to do a one-way presentation, but we want to hear some comments from all of you. As Zoltan mentioned, after the presentations, and plenty of time will be left for your questions or feedback. I encourage each participant to actively take part by asking questions and contributing to this discussion. Your diverse experience and perspective enrich the dialogue and contribute to the overall success of this event. Thank you for your participation in advance, and I wish you a productive and enlightening webinar. Thank you, Zoltan.
Thank you very much, Piotr. So next, we'll hear from our first speaker, Professor Rory Branach, who will talk about the list of antimicrobials reserved for treatment of humans. Rory, the floor is yours. Thank you.
Thank you so much, both to Piotr and to Zoltan, for that welcome. And the pleasure to be at this info session actually is all mine. So we've got a long title there. And as Piotr pointed out, we wanted to try and explain to our colleagues in the field why we devised the list and why certain antimicrobials went on the list. So just a little bit about my own background. I've more than 30 years experience as a clinician, and up until a few months ago, I was the clinical director of the vet hospital at the Dublin Vet School. So the problems you have in the field were exactly the same problems that I have. And a lot of the decisions we have to make would be joint decisions. And I like to see this from a field veterinarian point of view, although as Piotr pointed out, there are other people who may not be practicing vets at this moment in time. Okay, so the background is relatively simple. I think all of our colleagues understood that when the new veterinary regulation came into force, we understood that the use of antibiotics in veterinary medicine was likely to drive resistance, at least in certain circumstances. We knew that that resistance could be passed from animal isolates onto human isolates, either through the food chain or through direct contact. And of course, we all accept that AMR is a major threat to public health and also to what we do as veterinarians in the field. So as pointed out by Zoltan, one of the main purposes of the new regulation was to try and actually put in place pivotal steps that would lead to prudent and responsible use of antibiotics. So I just want to set the scene. The initial invitation came from the Commission in July 2019, and a group of experts, veterinarians, medics, microbiologists, people from ECDC and so forth, met up in Brussels on a beautiful summer day, and we all sat around talking and introducing ourselves to each other over a cup of coffee, and it was very collegiate. But after about an hour, it became a little bit tense. And the reason it became a little bit tense is this. Oh, I'm so sorry. Bear with me, folks. So this is the reason it became tense. What happened was both sides were a little bit defensive. Veterinarians had a huge worry that every antibiotic was going to be considered important by the medics and therefore would end up on the list, and the list would be exhaustive. Whereas the medics had the worry that vets would be defensive and try and define that every antimicrobial was also needed in veterinary medicine. But what happened, even at that meeting, was really, really quite encouraging, because we both groups all decided we needed to strike a balance. Vets need to be able to do their job in the field, and medics need to be able to do their job, particularly when treating life-threatening or serious infections. So we got this balance, and we developed forward with an ethos of balance. And that balance proved to me two things. Number one, One Health can work. And number two, the European project can work. So if you look at the timelines, I already pointed out that in July 2019, the initial request came from the Commission. But it was in February 2022 that we actually sent our report to the Commission. So you might say, how did it take you over 2 years? What were you doing? Well, the answer is simple. If you look at what happened at various time points, we did this exercise in a really exhaustive and very diligent fashion. So we looked at nearly 1,000 references. We looked at over 50 classes or subclasses of antibiotics and antivirals, and we looked at between 6 and 10 antifungal and antiprotozoal classes as well. A huge amount of information had to be actually researched, and we were adamant we wanted to get it right. Because if something had to go on the list, there had to be a robust scientific reason why it needed to go on the list. And we wanted to ensure that vets were allowed to do the job that they were required to do, and which of course society requires us to do. But in February 22, we submitted the report, and then in the summer of 2022, it was adopted, obviously as an implementing regulation. Where did we get the information from? In the previous slide, we talked about the fact that we had over 31 experts who were directly involved in the process on a regular basis. But other additional experts, and I'm particularly grateful to the European Society for Clinical Microbiology and Infectious Diseases, that gave a huge amount of input as well. But we had to go through all the peer-reviewed scientific literature, which was exhaustive. We also went through the grey literature, and by that I mean things like, prudent use guidelines, maybe government papers, reflection papers, that kind of stuff, and textbooks. And it came as a bit of a surprise that some of the main key drivers for using certain antimicrobials were actually only contained in textbooks. Not all those textbooks actually were that recent. We also looked at the categorization list that already existed with the WHO, OIE, and obviously the WOAH, and we looked at all the prudent use and antimicrobial stewardship guidelines that were obviously in place in the European Union and also worldwide. We then went with an open call for data, and that's when we surveyed the profession and we asked you, what are you using, why are you using it, and why do you think it's essential? Also, what would be the impact on your ability to do your job if in fact that antimicrobial was taken away from your general use? And finally, of course, we did have to rely on expert opinion. And I think I want to be very open and honest to say that, particularly in the area of resistance data, there are not a lot of publications on the veterinary literature. So on certain occasions, we did have to rely basically on the expert opinion of a large group of people. But when we got a consensus, we were confident that we were going in the right direction. So the methodology used. There were 3 criteria that had to be satisfied, and all 3 criteria had to be satisfied before the substance could appear on the human reserve list. The first was to establish whether or not the molecule was actually essential in human medicine. In other words, was it so important because it was used to treat significant disease or life-threatening disease, and maybe it was the last line of defense or one of the last lines of defense. If it didn't meet that criterion, the exercise stopped, and that product would, or that substance would not go on the list. The second criterion was, even if it was really important in human medicine, did we actually have hard data to suggest that the use in veterinary medicine would drive resistance, and that resistance would likely transfer into the human population? And finally then, even if criterion A and B were met, we asked the question, well, is this molecule essential for veterinarians to do their job? Because if it wasn't essential, criterion C could actually have been met. So just to reassure you, 3 criteria and all 3 had to be satisfied. So what we were trying to do was apply robust science and a certain degree of pragmatism to our decision-making process. What was the outcome? Well, even at step A, it gave me confidence that the medics were true and the microbiologists were true when they said they wanted a One Health approach, and they didn't want to be unreasonable in any request they made. So if you look at the amount of antimicrobials, which straight away the medics said, they're important, of course they're important, but we have other alternatives, or we have second or third lines of defense, and therefore we're not going to say that they meet criterion A, and straight away they were taken out of the exercise. Even when we took those molecules that did satisfy criterion A, when we asked the question about resistance and the actual scientific data to show that use in animals would drive resistance in humans, the only substances we used, for example, that didn't meet the criteria were those used to treat TB and mycobacteria, the aminophenazines such as clofazimine, and sulfones such as dapsone. And finally then, when we went to criterion C, and we asked the profession and we went through the literature, we went through all the actual scientific publications to find whether or not the molecule was essential. Now I need to be honest about this. Virtually every antimicrobial had been used at some stage by some practitioner in some scenario. So it wouldn't be enough to say, oh, there's some reported use of an antimicrobial. What we had to show was that if we removed it from the veterinary sphere, it would lead to a significant negative impact on animal health and welfare, and possibly production as well. So what was the outcome? When we look at antibiotics, you can see that there was a list of antibiotics. There were 11 classes and 6 individual substances which were placed on the human reserve list. In the case of the antivirals, there were 18 antiviral substances. Now, the vast majority of what you see, if it appeared at all in the AMA categorization, of course, it appeared in AMA category A. So I showed this list to a colleague in work, and I said, what do you think? And her response was, well, Rory, if I'm being honest, nobody wants to see that they can't use a certain antimicrobial. But if I look at those on those lists, either A, I've never used them, or B, I've never heard of some of them. So from that point of view, at a pragmatic level, I don't actually think it's going to negatively impact on what veterinarians are doing in the vast, vast majority of cases. On the antiviral side, I would like to point out that initially we did consider remdesivir to be suitable for the list, but it was clear that remdesivir did have a key role to play in the treatment of FIP in cats, and remdesivir was taken off the list. So having established the list, whatever, I just want to give a couple of slides, again, going back to some of the basic principles of prudent use. And I don't want to teach my colleagues to suck eggs, because I know a lot of you know, and we're singing from what I call the same hymn sheet. We all have the same modus operandi and the same goal. But some veterinarians feel that all they have to do is quote the 6 R's, the 6 rights, as in the right animal, the right diagnosis, the right antimicrobial, the right dose, whatever. And that is very important, but there's more than that which needs to be taken into account. So one thing I always teach my students is that you have to have an initial overview of what's happening on the premises, whether it be a stables, a farm, or a kennel. Have you got a mastitis problem? Have you got somatic cell counts? Do you know what the incidence of strangles is in an equine stable? Level of kennel cough? Level of FIP in a category? And the other thing is you need to know what the susceptibility and resistance data is in general. And there are 2 main tools that you have available to you. There's a lot of national data which the local laboratories and regional laboratories will publish, and they're going to be published in scientific journals. And you do every year need to read those. But equally within your own practice, what I would encourage you to do is every time you do culture and susceptibility testing, after a period of time, get all the reports together and see if there are any common trends for pathogens identified and antimicrobial resistance identified as well. On the points 4 and 5, I just want to re-emphasize the point that we can never rely on antimicrobials to make up for poor husbandry, a lack of infection control, or a lack of surgical sterility. It's just not appropriate anymore. It should never have happened, but even if it did, we need to make sure that we put an end to such a practice. And of course, even if we have an infection, we've got to ask ourselves, could we have another strategy, such as maybe a vaccination policy or the use of antiseptics rather than the use of systemic antimicrobials? Finally, then, I have a radical idea. The next time your loved one says, "Happy birthday, darling, what can I buy you?" Instead of Taylor Swift tickets, you might say, why don't you get me a modern pharmacology text? One that'll be up to date on pharmacokinetics, dynamics, concentration-dependent antimicrobials, time. Because let's be honest, the longer you're out of college, sometimes you forget some of these key objectives. The second thing I want to point out are the specifics though. I think we owe it to ourselves, our profession, and our clients and the animals we treat to make sure that we're as accurate as possible in our diagnosis. And then we call on board all of our clinical acumen, but what is the ancillary information that allows us to believe that there truly is an infection going on? What's the white cell count? Is the animal pyrexic? Can I do cytology and find degenerate neutrophils? Can I do these in-house tests for acute phase proteins? And I know those tests normally just indicate inflammation rather than infection. At least they give you some solid foundation that when you push forward, allows you to make a clinical diagnosis of infection. However, culture and susceptibility testing is the benchmark. If you can't do culture, again, molecular tests such as PCR would be identified as well. But the industry has moved. In the past, we were largely relying on disk diffusion methods, the Kirby-Bauer method, to give us an idea of what antimicrobial was likely to be the most appropriate. Now we need to identify clinical breakpoints. It gives us far more accurate information and it leads to optimal selection of the antimicrobial. If an antimicrobial is needed, make sure it's the right one at the right dose and the right duration. So in Dublin, one of the steps that it initiated was that the laboratory would never report on category B antimicrobials, I'm talking about the EMA category B, until they'd shown that those in category C and D did not work. And that way we stopped vets from automatically reaching for a fluoroquinolone or a 3rd generation cephalosporin. Of course, acute emergencies exist. If I have an animal with septic peritonitis, I know I'm probably going to have to straight away, I don't know if it's aerobic infection, anaerobic, gram positive, gram negative. And in that case, I will give combination therapy. I'll give amoxiclav and enrofloxacin. But when the data comes back from the lab to tell me what it is, I would then de-escalate if I can. And then the other final feature is that we do repeat culture, particularly things like respiratory infections or urinary tract infections. I need to know at the end of treatment, have I got a relapsing infection, refractory, resistant? And that again allows me to optimize my selection and use of antimicrobials. But I do want to be honest, and I want to acknowledge that we live in the real world and we don't always get it right. I don't get it right, so how can I expect my colleagues to always get it right? And of course, we have to initiate treatment before we have the results of culture and susceptibility tests. But the one thing that we always want to encourage our colleagues to do is never to use this phrase, I'm going to cover the animal with antibiotics. I'm not sure what's going on, so I'm just going to cover. In that case, go back to the whole thing about a clinical diagnosis. Go back to the concept that I've got culture and susceptibility testing underway before maybe you make that decision. But even with that and with the right kind of ideology, you still will face ethical issues. So recently, 2 cases I had to deal with one was a dog with Pseudomonas, multi-drug resistant Pseudomonas in the ear. And clearly the only step forward was going to be surgery to do a total ear canal ablation. But the client's insurance didn't kick in for another 4 months. So my question to me was, will you give him an antimicrobial with intermediate susceptibility to keep it at bay? Another one was a chronic lobar pneumonia. There was an abscess on one lung lobe. That lobe needed to come out, but the animal was a huge anesthetic risk. So always, despite always having the right ideas and the right desire, whatever, I do accept, and we all accept, that in the field, it isn't always as easy as you would like. But what I do want to say, and the main point is, I think the FVE and the national organizations have really tried to put in place prudent use guidelines and to buy into the concept that if there is a human reserve list as to why it needs to be. So we're talking about the responsible and the prudent use. We have made great strides. And I think through the efforts that vets in practice have done, we're making the One Health initiatives more likely to succeed, and we are contributing towards tackling AMR. The final thing I just want to do very quickly is just to remind about the EMA categorization, and in particular EMA category A, because as many people will point out, there are certain antimicrobials that when this list was last refined, it was before this exercise for the human reserve list. So some of the antimicrobials you see there to avoid, and obviously try to ensure that you don't use, that's no longer possible. It would be illegal to use them. So of course, at a future time point, very shortly, we will revise the EMA category A to remove those drugs that would be illegal to use. But again, with regard to B and C, it's the whole point of escalating down. Start with category D, and if your culture results don't give you confidence that category D will work, then you think of category C, and finally category B. In particular, I'm very careful in my own hospital to try and remove or reduce the use of category B antimicrobials. So category D, as I said, is our first line defense. And the truth of the matter is, if you look at many countries that have had prudent use principles in place for a long period of time, it's incredible to see the number of isolates that are still susceptible to simple penicillin. And there's a lesson there, and a lesson for all of us. So I'm really, really grateful just to have that short presentation. And as Zoltan said, any questions that you have, we're very happy to do through the Slido process, but I'm going to hand back to the chair at this point. Thank you.
Thank you very much, Rory. And here I think we can mention that those who are interested in this scientific advice, which were presented in the beginning of your presentation and would like to read a couple of hundred of pages, they can find it on the EMA's website. And the list, I also would like to underline, as you mentioned as well, that it's now a Commission implementing Regulation 2022-1255. So thank you again. And now let's turn to our second speaker, Dr. Andreas Palzer, who will talk about the WHO list of medically important antimicrobials. Andreas, over to you.
Yeah, thank you, Zoltan, and thank you for the possibility to present a little bit what was done by WHO. And I can only support the first speaker. Also, we at WHO, we met in a big group from all over the world, and people from medicine, from the laboratory, veterinarians, and it was a very, very good working together in the sense that we all thought working on the same goal. This was my impression during the work we have done. Our task was to renew or to work on the old CIA list and to make it to a new and to look what can be changed. And perhaps we can have the next slide, please. So I have taken the slides which were created by WHO. Many thanks to Jorge Mateo. He had these slides created. I will talk very brief about the background, what was done in the revision process, what is the purpose of the list. This is for me a very important topic than the classification and how it was done. So we can perhaps go on the next list. Perhaps you know, this is a list coming out of a long process, and there were several lists before. The first one in 2005 and 2007, the last one in 2019, and it is seen that regularly it is undertaken a revision process and to look what can be changed. Up until the last version, it was always the critical important antibiotics list. Now the name has a little bit changed to medically important antimicrobials list, so the MIA list and not the CIA list. And this is because we have done some bigger changes, especially in the categorization. Up until now, it was only critical, highly important, and important at the start, and now we have new groups in the classification. So perhaps the next slide, please. So the group was established in 2021. There are 17 members out of the whole over the world of the 6 WHO regions. And this is also very important as we have now the quadripartite, also from the FAO, from the United Nations Environmental Program, and from the World Organization of Animal Health. People were part of the bigger group to discuss the new list. So the One Health approach is clearly seen here, because we have food, we have environment, we have the animals, and we have human medicine all working together. And we had some tasks which were defined before we met by doing in the revision process, especially, of course, the list. Is there changes in the list? The second task was looking especially on macrolides and on other classes on antimicrobials, if it could be changed or must be changed, and a change in the prioritization factors. There were a public discussion, and it was just published some weeks ago. So next slide, please. These are the people working together from all over the world. From Europe, it was Gérard Moulin. From France, Professor Bruno González-Zorn from Spain. I from Germany, and where is she? I miss her, from England. So next slide, please. So the purpose is to ensure that all antimicrobials, especially those who are judged as medically important, are prudently used in all sectors, which includes animals, but perhaps also human medicine and plants, of course. It focuses here in the first step mainly on animals, in my understanding. And it is the purpose to help regulators and stakeholders how to deal with these classes and to put a higher risk on humans. So to look on the regulation and so on, and to change perhaps things there. The target audience, in my understanding, are mainly the veterinarians who are using the antibiotics and shall not use some classes, and others only, as we have heard already in the first presentation, on a very low level. But of course, national regulators and policymakers, not all over the world, we have such an advanced regulation as we have it here in Europe. So it also wants to emphasize that we need a surveillance and that we have a regular review of the antibiotic used in the field. And of course, also those who produce with animals, for example, food animal producers and purchasers and food companies are also addressed to look on the list. So next slide, please. So what we have done is a little bit a similar approach, but a little bit different. So we have looked on all classes on antimicrobials, and normally in the first time, as I said already, we have critical, important, and so on. Now, in our first step, what we are looking for was the authorization status. Because if I talk to animals and to veterinarians, of course, and antibiotics only authorized in humans are not so important for this group. So the most important group for veterinarians and where we have to focus on, in my understanding, are those antibiotics who are used both in humans and animals. And there are some antibiotics also only authorized in animals. So, for example, quinolones are in both groups, where others are only authorized in humans or in animals. So if you see here, quinolones, cephalosporins, and phenycols, where we have some antibiotics used in animals and some in humans. And they share, for example, if we talk about enrofloxacin and ciprofloxacin, in the resistance mechanism, they share certain structures. So next slide, please. So as I already said, we looked on the current authorization status. Of course, there can be changes. I don't think that there will be many new antibiotics authorized for animals. Mainly the new ones will be authorized for humans, in my understanding. And we have focused if any member of the drug class was authorized in any country. So, of course, there are some antibiotics which are not authorized for animals here in Europe. But for example, in other regions, they are authorized. So they are grouped in a group of authorized both for humans and animals. The best practice statements coming out of the document is our recommendation. Normally, we shall not do such recommendations because they must went through a different process in WHO, but we can say we have certain best practice statements that any new class which will be authorized only in human will automatically be placed in a category only requested for humans. In my understanding, this is logical because they will be reserved only for humans. And we don't want that any of the antibiotic classes which are currently only authorized in humans should not be authorized in the future for mainly use in food animals. So, of course, those who are already in a group only reserved for humans shall stay in this group and shall not change their authorization status. So, next slide. Next. Can I click it now? So we have certain classes. So the black ones on the left side only used authorized for humans, then those both humans and animals, and the green ones only authorized for animals. Then we have medically important antibiotics, which are mainly those two classes on the left side, and not medically important antibiotics, which are the green ones, only authorized in humans. So we have already one class, not medically important antimicrobials, only authorized in animals. So, and those who are the black class, the left class, only authorized for humans is also clear because they are only authorized there and shall only be used there. So the main target of the revision process and of the process in the decisions tree, how we make a group, in which groups we are putting them, is those antibiotics used for humans and for animals. So they need a further analysis, further steps to be judged if they are placed in the HPIC group, so highly priority critical important antibiotics, or in the CIE group, or in the important antibiotic groups, which are on the left side. And these 6 groups, if you want, from the black ones, authorized only for humans and authorized only for animals, and the 4 ones between, they are judged a little bit on the high AMR risk to the low AMR risk. This is the principle which is which stands after the process which we did. Next slide, please. Next slide. So if we have those only authorized for humans, next slide, they are judged as very, very important for humans. They are not authorized in animals, so they should not be used there. They should not be authorized in the future for food-producing animals and crops. And they are seen as the most critical. Especially as some of them are judged by the human medicine side as sole therapy, last resort therapy. So next slide. If we look now on those groups of antibiotics which are authorized in humans and in animals, they need a further judgment. And the first step in the judgment is we have in our decision tree two criterion. Criterion 1, which is asking, is it the sole or one of limited available therapies to treat serious bacterial infections in humans? And the second criterion, is this antibiotic used and is there a possible transmission from non-human sources or with resistant genes from non-human sources? So we have two criteria. If they are fulfill both criterion 1 and 2, they are already critically. If they fulfill one of these two criterions, then it is highly. And if it's one or two or none, if it is none, so not criterion 1 and not criterion 2, then they are important. And then on the group which fulfill both criterion 1 and 2, which are critically, we apply the prioritization factors. The prioritization factor 1 was changed because in the last document, prioritization factor 1 and 2, they were very similar. So they were changed, and our idea was in the prioritization factor 1 to make a link to already existing lists in human medicine, mainly the essential medicine list and the watch and or reserve list which exists. So, and then we apply prioritization factor 1 and 2. If both prioritization factors are met, they are in the highest priority critical important group. If it is none or one prioritization factor, they are critically. So we have here our different groups, the 4 groups coming out of the group authorized for humans and for animals. And here's one example. If you look on fluoroquinolones, perhaps next step, they both fulfill criterion 1 and 2. So they are critically. And on this group, we apply the prioritization factor 1 and 2. So looking, is there one antimicrobial out of this group on both the essential medicine list and watch and reserve on the aware list? Then it fulfills prioritization factor 1. Fluoroquinolones are fulfilling this prioritization factor 1. And then the prioritization factor 2 is the question, is this antimicrobial used to treat infections in people which there's extensive evidence of transmission of resistant bacteria or resistant genes? So the main question about resistance transfer from non-human sources. And that these infections are frequent causes of invasive and life-threatening infections. So it is not sufficient that there exists one case per year where perhaps it fulfills the cause of life-threatening infections. It must be a frequent cause. And the people represent, especially of course, from the human side, I said we have a certain threshold, how many cases of 100,000 people that we talk about frequent cause. And if you look on fluoroquinolones, they fulfill both in prioritization factor 1 and 2, so they come out in the highest priority critical important group. Next slide. There are some changes, and they are a little bit different from the categorization, from the AMA categorization. Some are similar. For example, I have seen that ketolides are also separated from macrolides in the AMA categorization. But for example, fidaxomicin were also separated because it is only human and it has a different spectrum of activity. Then we have the reclassification of macrolides. They were downgraded from HB-CIA to CIA, and aminopenicillins from CIA to HCIA. But for example, phosphoric acid derivatives, they were reclassified and they were upgraded from CIA to HPCIA. And also nitroimidazoles were reclassified and upgraded. So we have some slight changes. Some were upgraded, some were downgraded in the categorization, but mainly the outcome was very similar to what we have had before. Next slide. So if you look here on the highest priority critical important antibiotics, in the old version, it was the cephalosporins and the quinolones and the polymycins. And they are also in the new MIA list, those which are in this group. And new in this list is the phosphoric acid derivatives. And critical important antibiotics, macrolides are now fulfilling or are now in this group. I'm very happy because perhaps our approach is different from what you have heard from in the first presentation, but the outcome is very similar. So also in the AMEC categorization, in the B group, we have cephalosporins, fluoroquinolones, and phosphoric acid derivatives. So a very similar outcome of a little different process. Next slide, please. The intended use, and this is for me very important. It is no in the document, no section written down that something is forbidden, but the goal is that we use antibiotics in a very prudent way, and that the prioritization helps, like the EMA categorization, look what is perhaps the best choice of treatment if mainly veterinarians are doing treatments. So the intended use is that we have a risk management strategy, and in some regions of the world, they don't have up until now a very good risk management strategy. It should be used in conjunction with the codex and also with some other lists. For me, this is very important because sometimes it is very confusion as you have so many lists. So the WOA, the World Organization of Animal Health, that's also a list with a classification, but it's a little bit different. And in my understanding, the best or the ideal goal would be to have one list, but it's very important, very difficult to create such a list. The list wants to develop national and regional policies for responsible and prudent use, especially of those in the higher categorization. And it wants to reduce or restrict the use of certain antimicrobials in non-human sectors, especially those in the higher categories. Next slide. So surveillance, monitoring, evaluation is one of the main goals. Stringent risk management in non-human sectors. And I'm always talking about worldwide. So this is a big issue. And also to strengthen communication of risk, because in some regions, perhaps antimicrobials are not seen as a big risk. The use is very open and very free. And we see it also in Europe a little bit that there are big differences between some countries in the usage of antibiotics. Some are using both in human and veterinary sector many antibiotics, and in other countries there's a use which is much more restricted use. So this is also about the communication and about the culture of our look on antimicrobials. Next slide. So in the summary, it is the MIA list of WHO is an important component of the global action plan on antimicrobial resistance. Some days ago, we have heard from WHO that there are more and more in the human medicine infections which could not be treated. We need new antibiotics, especially developed, and there are a lot of difficulties that the companies, pharmaceutical companies, are developing new antibiotics. The MIA list wants to support member states in the developing of national policies and guidances, and to improve surveillance programs and promote research activeness and intentions. And the third goal is that we have to have one voice and also a one health approach on national and regional global levels. And I think that we have heard already in the first presentation in Europe, in my understanding, a lot of these goals are already fulfilled, but some perhaps need to be refined, and we need to work a little bit more on it. But we are on a very good way in Europe, in my understanding. Next slide. So thank you very much. The whole group was sponsored by the government of the Kingdom of Saudi Arabia. So many thanks to them. And now I'm open for the panel discussion. Thank you.
Thank you very much, Andreas. Okay, so we move now to the question and answer session. Again, a reminder to the audience that the session is being recorded and it will be made available on the events webpage on the upcoming weeks, together with this presentation. Participants can ask questions via Slido. Please go to www.slido.com and type #infosession_23May, or use your smartphone, just point the camera at the QR code. Okay, actually, I have a question first, if it's all right, Rory and Andreas. So in Andreas' presentation, the WHO Maya list was presented. Andreas, you also mentioned the VOA list. Rory, in your presentation, the human reserve list and the AMEC categorization were mentioned. Could you maybe elaborate more the use of this list? What are the differences? Anything you would like to add? Thank you.
Yeah, thank you very much, Sultan. And as Andreas pointed out, it can be very confusing for veterinarians when they see all these different lists. And they ask the question, is one kind of prioritized over the other, or should it be paying more attention to one? A couple of points just, first of all, let's really emphasize that the human reserve list is a legal restriction. So it's not a guideline or a piece of scientific advice. It's off the table, right? So just be very, very clear about that. So we must understand that the different groups, whether it be the OIE, whether it be obviously the World Health Organization, we have different mandates and we cover different jurisdictions. So the one way that I would put it is that if the world was homogeneous and all animals and humans were the same in terms of disease exposure, disease incidence, access to antimicrobials, for example, we know that in some countries, what we would consider to be the first line of defense would be the last line of defense. That's just a socioeconomic reality. So when you look at the fact that it's such a heterogeneous world out there, both in terms of disease exposure, incidence, animal, the way they're cared for, socioeconomic factors, it's not really possible that there's just going to be one guideline that will cover the entire world. I wish there were. But within Europe and for the FVE, the main audience here today, I mean, I can simply state from my point of view, as a member of the CVMP, that the EMA categorization, that is the actual scientific opinion and advice of the CVMP that would be most relevant to veterinarians within the European Union. That does not mean that you should actually ignore the other, obviously, guidelines, because, you know, in knowledge, whatever, you always have to think outside the box as well. But from the point of view of doing prudent use and responsible use of antimicrobials in veterinary practice in the European Union, I think it would be fair to say that the EMA categorization is the first protocol. Thank you.
Thank you very much, Rory. And here I would like to mention that the second EMA FVE webinar was actually about this AMEC categorization. So if you are interested and would like to learn a little bit more about this, I think we can be sure that we can link that webinar to this event page as well. I also just would like to ask Andreas if you would like to add anything else, or?
Yeah, I think that the MIA list of WHO has more or less the same goal as the AMEC categorization. So to look on the different antibiotic classes and to make a judgment on them, in which group they should be put. And of course, it is a worldwide question, and the world is very diverse. But if we compare the two lists, and of course, AMEC categorization is law, so it is a regulation and it is not a wish to, but the outcome is very similar because the question was very similar. If you look on the WHO from the World Organization of Animal Health, the question is a little bit different because they are looking what is important for animals and so on. The question is different, so the outcome is different. So if we compare different lists, we have always to look what is the question and what is the idea behind. And I find it very positive that we have here now two lists which have a very similar question and the outcome is very similar. And of course, Europe is always a little bit on the frontier and we are on the front line. And in other countries, it is perhaps not so developed. But we have different lists, but if they have the same question, then the judgment is more or less the same. And this is very positive for me.
Thank you very much, Andreas. I can see two questions. So the first one is, will the slides will be provided? Yes, I can say that these presentations will be uploaded to our event page. The next question, will the AMEC list be updated every so many years? And if so, what will be the process? So I can take this question. What will happen, like that, according to the recommendation, which is in the AMEC advice, every 3 to 5 years, there is a possibility that the AMEC list will be updated. But here, it really depends on, for example, new data, new scientific data, which would make it necessary to update the AMEC categorization. And the process is basically is that here at the European Medicines Agency, we organize this review after we receive the mandate from the European Commission. So this is the process. We receive a mandate and then we form a working group which will provide advice to our committee, to our CVMP, which will be adopted, and then the AMEC categorization is updated. Okay, I don't see more questions, but Andreas, I was also thinking to ask you something. You mentioned macrolides in the WHO MAIA list, which were previously HPCIA and now CIA. Do you want to elaborate a little bit more on this one? I can say that here at the European Medicines Agency, we are working on the revision of the macrolides reflection paper, so I would be interested in your feedback. Thank you.
Yeah, this was one of the main questions because the decision in the old list was doubted by certain people, and there are even publications about it. So I think there were two important decisions. First, that two macrolides were separated from the whole group of macrolides. So fidanomycin and ketolides were separated, and they were put into the authorized for humans only group. This was the first step. And the second step was that we had a discussion about if macrolides really fulfill prioritization factor 2. So if you remember prioritization factor 2, we are talking about life-threatening infections. And of course, there are some of infections coming out of the food chain, like Campylobacter rosis. But in most cases, they are self-limiting. And even antibiotic therapy is not considered to be done, and then why? So there are only very infrequent causes of invasive and life-threatening infections. So this was the main reason why they were downgraded. Yeah, and it's very well explained, all the decisions about changes in the document. But this was the main point, that people, especially from human side, they said to us they will not fulfill prioritization factor 2. And this was the main reason for the changes, but also to separate perhaps two classes.
Thank you very much. Actually, I was happy to see this because the AMEC categorization also contains quinolone cephalosporins, 4th generation cephalosporins, and polymyxins in category B, and macrolides are in category C. Question to Rory, what are the 6 R's?
Yeah, thank you very much for this. One of my colleagues said, I thought there was only 3 R's, but this is totally different from the 3 R's principle. The 6 R's are that when you make a decision to prescribe an antimicrobial, first of all, you have the right animal, you've got the right diagnosis, you've got the right drug at the right dose for the right duration with the proper and right storage and disposal. So the 6 R's. Make sure you're correct in your diagnosis, you have the right animal, It's the right drug, the right dose, the right duration, and the right storage conditions to make sure, again, that you don't lose any efficacy. So those are the 6 R's, and it's mainly applied in farm animal practice. So this is largely one thing that's come from prudent use principles in farming. Thank you.
Thank you, Rory. Question to Andreas. What is AMR Codex?
Yeah, the AMR Codex is a codex published, if I'm not wrong, by the Commission. It's a guideline of risk analysis for foodborne antimicrobial resistance, so Codex Alimentarius. And we are reacting to them because this is also from different organizations, a strategy plan to focus on AMR.
Thank you very much. And now I would like to give the floor to my colleague, Barbara Freischem.
Thank you very much. If I may expand that response a bit. Codex Alimentarius is indeed an international organization, and it is WHO and FAO of the UN that are involved, and the main aim is to ensure safe food for all across the world. And of course, as soon as food of animal origin is involved, you also need to think about antimicrobial resistance. There are a number of documents developed by Codex, mainly with a view to looking at the food supply chain. And you mentioned the World Organization for Animal Health before. They look more at the food producing animals where they are kept and bred. And that's where also the list of antimicrobials of veterinary importance comes from. So as you are working for the WHO on the list of antimicrobials of veterinary of medical importance, Codex integrates the food supply chain, and WOA looks at the animal health aspects at the global level. Thank you.
Thank you very much, Barbara. I can see one more question which I would like to address. It says not every veterinarian is aware of this list. Will FVE communicate this at the member states level? I can see Nancy is online. Would you take this question? I guess I know the answer already, but please.
Yes, with pleasure. So my name is Nancy Debrie, and I'm the executive director of FVE, and we're really trying to communicate this list. And like you've seen before, EMA has made this very nice infographic of the AME categorization, which is available in all European languages. So we have been heavily communicating that one. In addition, we're at this moment, FE is involved with running workshops in all the European countries. And there also we try to communicate to as many veterinarians as possible. Because like we heard, it's really important that everybody has this listing, both knows about the reserved list and the AME categorization list. To use in their daily practice.
Okay, thank you very much. This is the end of our webinar, so I would like to take the opportunity to thank the presentations of our speakers, to answer to the questions, and thanks to all of you who attended for your active participation in today's event. And actually, I will now give back the floor to you, Nancy Debrie, FVE's Executive Director, for the closing remarks. Thank you.
Well, thank you very much. I hope you all enjoyed this webinar and that it gave you more insight on why this reserved list of antimicrobials for human medicines was made, and also about the rigorous methodology that was used to decide which antimicrobial to place on the list and which not. We all understand that antimicrobial use in animals can contribute to the development of resistant bacteria, and that can affect humans and the environment and vice versa. And therefore, it is really crucial to use antimicrobials prudently and responsibly across all sectors. And as Rory explained, a true One Health approach was taken, considering both human health and the needs of the animals for developing this reserved list. I hope we also managed to clarify a little bit why we have all these different lists, and that for us veterinarians in Europe, the AMEC listing, the AMEC categorizations, which was shown in Rory's presentation, is the most important. Together, of course, with reserved list, because that's a legal requirement. The antimicrobials on the reserved list we are no longer allowed to use. Antimicrobial resistance is a real One Health issue, and we cannot solve it by one sector alone. All sectors where antimicrobials are used must contribute to this effort. However, in our sector, the animal sector, we can be proud because we made already significant progress reducing antimicrobial use for over 50%, and this without negatively impacting animal health and productivity. But we can go further and become champions for change and advocates for responsible and prudent use and ambassadors for improved husbandry and animal management. Our next webinar is foreseen on a topic of extremely importance to veterinarians, namely the cascade, Articles 112 and 114 of the new regulation. We are now awaiting the adoption of the final act on the restriction on the use of antimicrobials under the cascade. And once this act has been adopted, we will start planning for our next webinar. So please follow the website and social media channels for update, because we hope to welcome you again for this next one. And finally, I also want to thank the two fantastic speakers, and also very much all the colleagues from the European Medicines Agency, who ensured everything runs so smoothly. As FVE, we are immensely grateful for the opportunity to collaborate together on these webinars. Thank you all for joining, and I wish you all an excellent further day. Thank you.